TopMed Talk.
Welcome to TopMed Talk, the broadcasting arm of EBPOM, evidence-based perioperative medicine. I'm here to tell you super early bird registration ends on the 31st of January for EBPOM World Congress 2006. It takes place between the 7th and the 9th of July at the British Library in London. 3 days of evidence-based perioperative medicine, global insights, and expert debate featuring speakers including Michael Marmot and Ken Rockwood. Super early bird registration ends on the 31st of January. Register now at ebpom.org.
Hello and welcome to TopMed Talk. I'm Andy Cumpstey and it's a real pleasure today to be continuing TopMed Talk's new Perioperative Profile series. Each month, a new Periop Profile episode spotlights the professional and personal journeys of some leading and inspiring perioperative practitioners and researchers. We'll explore how they came into the field, what shaped their careers, some of their key challenges and successes, and how their work continues to contribute to evidence-based perioperative practice. Today, I'm really delighted to be joined by Professor Lee Fleischer sharing his Periop profile. Lee is Emeritus Professor of Anesthesia and Critical Care at the University of Pennsylvania and a former Chief Medical Officer and Director of the Centers of Medicare and Medicaid Services in the United States. But more than this, as we'll hear, Lee is still an active clinician, a passionate researcher, a dedicated national policy maker and advisor, and a very caring family man. Lee, thank you very much for sharing your profile here on TopMed Talk.
Thank you so much, Andrew. It's always a pleasure to be talking with TopMed Talk, and the evidence-based perioperative medicine group has always been a highlight of both the year when I go to the meeting and also continuing. I'm currently the co-editor-in-chief with Mike Grocott of the journal, although because of some of my current roles, I am phasing off. But as you mentioned, I still love giving anesthesia, and I'm the former chair at Penn and an emeritus professor, but they let me come back. I don't do my vascular cases anymore. I do more of the ambulatory cases twice a month, giving anesthesia back at the hospital of the University of Pennsylvania. But after I left the federal government, I did a number of things. One, I set up an advising firm with my son. It's called Rubrum Advising. Rubrum is actually the name of a lily that I gave to my wife when we were courting and continue to give her to this day. So over about 35 years, she's gotten rubrum lilies. So we decided to name it after the lily. And we're now up to about 15 people who work directly for us, 25 people total. What we do, which has been really interesting, when I was in the government, I made decisions about what the federal government, the Medicare program, would pay for, which we can talk about later. In the US, once something gets approved by our FDA, particularly for devices that are not used outside the hospital, but even some in the hospital, Medicare then separately decides whether to pay for it. And the commercial insurers in the United States decide that. So we help companies get coverage of their devices from FDA work. I have an FDA attorney and a specialist we have actually 3 former CMSers, the most number, who have worked in the coverage space. And we do some policy and regulatory and try to educate around this. Just yesterday, I was up on Capitol Hill talking to a few members of Congress about good policy around coverage. I'm also have a privilege that a number of think tanks in Washington asked me to participate, and still being clinical and, being a perioperative physician, we know a lot about some areas, but we know a little about a lot of areas. We have insight into how care is given. So there's something called the Bipartisan Policy Center, which advises Congress on numerous issues, set up by a number of former senators. I'm a senior advisor there and help them particularly with their artificial intelligence work and their affordability work. I work at something called the Duke Margolis Center and help them in policy around coverage, AI, and some drug work. Milken Institute has something called Faster Cures. How do we get novel medicines, novel technologies to patients faster? I just with the group at the JP Morgan meeting in San Francisco, where I was one of 3 men with 17 women talking about women's health and how do we actually ensure that what in the United States is unfortunately considered wellness care, but in many places, and particularly if women were in charge, would probably be considered health care. How we can ensure that women get the same sort of health care as men that's paid for by our insurance system. I also am working with them on how can we use data to advance healthcare and what's the future of biomedical sciences in the US. And then I'm an advisor to one of the agencies in government on health IT information, something called the high tech. So I pretty much have what one of my mentors called a portfolio of activities in that policy space. But my anesthesia background and learnings, given we touch everything, really has been indispensable to helping me inform all these bodies and how to think about good policy.
Wow. I mean, the first thing to say is what a inspiring and fascinating, as you say, portfolio career. But I guess at the heart of that core clinical anesthesia work that you're still doing has really sort of opened all these doors for you. So go on, how much of the time are you still spending in the OR? How much are you still doing on a weekly basis in these kinds of patients?
It's, I'll do about 11 patients is my list, as you would say, in the UK. I love doing parathyroid and thyroid surgeries. We usually do 8 cases with one surgeon. And then I usually have a third room with nurse anesthetists, sometimes with residents. But you're right. It's interesting. I stood up something in the US called Hospital at Home. And I just wrote some editorials about it. It's essentially taking the ICU and the ward to the home. And I wrote about how novel technology, the ability to do remote monitoring, can change the way you think about it. I have an article in Stat on that. Well, that's what anesthetists and, more importantly, intensivists do. So all that work in perioperative medicine translated to when I stood it up in the federal government, the waiver, and now continue to do that work. The other area I've been doing a lot of work is brain-computer interfaces. We do a lot of monitoring of the brain as anesthesiologists. One of my roles was supervising the team with the Department of Neurosurgery and Neurology, the neurointensive care unit. So all of that is helpful. And then actually I'm working with a couple biopharmers on their board, and they're in the stroke, myocardial infarction, cancer spaces. Again, we take care of cancer patients. We take care of stroke patients. I think people are surprised by the breadth of knowledge, but I've been part of the perioperative community, not the stay in the OR community for so long, that I've learned from all my amazing colleagues.
Let's jump right back to the beginning then, Lee. So before you got into that perioperative space, where were you at school? Where did the idea of thinking of a doctor career, a medical career come from? Were your parents medical? Was it something you just stumbled into?
So I had an uncle who was a physician, and my grandfather, although at the time was in retail, was a pharmacist by training. And I just love science. I still remember in the 5th grade doing this huge board of how muscles worked. So always planned to be a doctor since, when I got to high school, which was in suburban Philadelphia, about a half an hour from where I live now, which gets to grew up in Philadelphia, outside Philadelphia. I met a science teacher who just stimulated me to want to do more. He had a PhD. He was one of my heroes. And at age 15, I went and started working in a laboratory at Jefferson Medical College in biochemistry. At 16, moved over to Penn and something called the Wistar Institute and started entering science fairs, won some minor awards, and really got excited about research. So when I went to Penn, where I ended up, and continued the research I was doing, my parents moved to New York, so I actually did some work at Columbia in molecular biology, took courses in molecular biology. Back then, for any of the crowd that is my vintage, they will remember Maniatis' spiral notebook. We were under hoods because we thought if we did restriction enzyme research, we would be creating monsters. We didn't. And now you do it at tabletop. But got to do that and ended up going to Stony Brook for medical school because one of the professors who trained at Penn, who was chair of molecular biology at Stony Brook, told me, come and I'll get an MD PhD. So still plan to do an MD PhD. And given I had done work in immunology, got very interested in transplantation, which we'll get to in a minute. Unfortunately, my mentor got a huge package to go to Princeton and now is in the Center for Advanced Studies there. And he said, rather than getting a PhD now, wait and decide what you want to do. So I applied to surgery for a program that gave me, very similar to the UK system, a PhD in immunology, and I was going to be a transplant surgeon. Loved taking care of the patients, hated operating, and over breakfast every day, one of my critical care attendings said, go be an anesthesiologist and then do critical care. Because it was always anesthesia and surgery, critical care would work together. I was at the University of Minnesota at the time, so I came back east and went to Yale, where I met another two mentors, Paul Barish and Stanley Rosenbaum. Paul, of course, is quite famous for the textbook, and he got me interested in cardiovascular risk assessment. So I really pivoted away from my basic science, been doing it for 10 years, and started doing clinical research. And I started doing Holter research with the Department of Cardiology, silent ischemia, and I made him a bet. I said, if I submit an abstract to a silent ischemia meeting in Israel, and this was right before Dennis Mangano started publishing a lot of his work, and they accept it, will you send me? Little did he know, nor did I know, that they accepted all the abstracts, and there were only 13 of us with 40 cardiologists, including Eugene Brunwald. I mean, a god in this field. And that's where I got really stimulated about all the risk assessment, was sitting in a room with 40 of the most famous, brilliant cardiologists thinking about risk assessment.
So that's fascinating. So actually all the way through it was the science, the research that sort of pushed you into medicine right from the word go.
Yes. When I was a senior in college, and this gets to, you never know the places you'll go, I said, do I really want to do research? I've been doing it since I was 15. And I quit doing research. I worked in a French restaurant for my last 6 months, and I wrote an essay of how I just wanted to be a doctor. When I applied, first of all, nobody understood it except for the professor at Stony Brook who said, you're a researcher. So I realized that research would always have to be part of my career.
And so initial flirtations, temptations with surgery didn't pan out as the way you expected, and you saw the light and moved over to anesthetics a little bit afterwards. How did things progress from there then? So you settled in anesthesia and critical care early on and went from there?
Yeah, so I did apply for critical care, but I got so enamored. It's funny when you transition, I've seen this over and over again when I was a chair. When you transition for surgery, in the beginning, you think anesthetics, it's so simple. The more you are involved, the more you get excited about what you do. And by the end, I didn't want to do a critical care fellowship. I loved vascular anesthesia. I became the chief of vascular my first year out at Yale. My friend Stanley Rosenbaum, my colleague, handed it to me. And I was continuing, except to celebrate the end of my residency, I went to Club Med in Mexico and met a woman on the beach who lived in Baltimore. So the second part of the story is, for love, you have to make a decision of what's best for you. In fact, I still remember my mentor saying, if you want your career to succeed, you should stay here, because I plan to. And in fact, I made her a deal that, if I moved, given I had, Paul Barish gave me a job and a career, and it was phenomenal, and resources. I had a research nurse when I was a resident. I would go to Baltimore and find a job, and I happened to start working with someone at Johns Hopkins, so it wasn't that I had to really leave and not go to another great institution. But in exchange, if Penn ever called me to be chair, I could return to my alma mater. And she will attest to this. And 13 years later, they did, much to her chagrin. But when I got to Hopkins, my ability to do the silent ischemia research was less effective. And I really pivoted to some extent to health services research. In addition, because I couldn't go into the ICU, they were doing competing studies, although I participated in many of their studies. So that's where I brought in my interest in and got involved in policy, health services research, etc. And what was exciting, and happy to talk about how I got involved with guidelines.
That was one of my questions later, but just before we get onto that, then let's pick up. So you made a massive career decision for family reasons. So family's really important to you. Tell us about your family.
So I'm very fortunate. My wife at the time was an attorney. She continued working until I took the chairmanship. So she retired a number of years ago. She was an attorney in Baltimore, and that was part of our decision processes. And I have two children. One is in tech in New York, revenue operations. My son, interestingly, worked in one of our labs, did not enjoy it, but he grew up with a father in science. He trained as a classical opera singer. Did that for a couple of years, decided that he wanted a more stable career, went and got an MPH at Hopkins with my colleague, who I did my policy work with, and a law degree. And when he finished everything was the time I was coming out of the government. So my son is now the president of the firm that I'm the CEO, and we are the co-founders of Rubrum Advising.
Amazing. What a journey.
I'm fortunate to work with a son and watch him do an amazing job.
Well, I guess that partly answers my next question of how do you manage to fit any family time in around all these amazing work things you're doing? And if you're working with your family anyway, that can't be your only family time, surely.
Well, my daughter's in New York, so we love going up. I see my son a lot, and now having a grandchild and a second one on the way very shortly, we get to see them on the weekends, and so that's exciting. My wife and I have different tastes in TV shows, so she tolerates me. I'm very fortunate.
Go on, I've got to ask about your taste in TV shows, and what doesn't she?
So she watches more of the investigative reporters and game shows, and I'm more of the motorist mysteries and particularly British murder mysteries, and Father Brown and Shakespeare and Hathaway, and all the PBS Masterpiece Theater.
Inquisitive minds coming out again, isn't it? I think it's in all of us researchers, academics, medics, and I'm probably very similar. But so you made this amazing pivot for family reasons, but that's really what opened this new avenue of policy guideline work. It was, I guess, sounds like it was more through opportunity rather than design. Is that fair? Or was it always on the agenda, something you wanted to get into anyway?
No, you never know where you'll go. And what happened is that the ACCHA, American College of Cardiology, American Heart, I started being a surgeon in a anesthesia. I always had a perioperative vision, and I always worked with the surgeons a lot and had phenomenal relationships. When the guideline committee set up the guideline, I think they picked me because I had published some review articles, and they didn't want any senior anesthesiologists because they never had an anesthesiologist on their guideline committees. This is 1996, or really no one senior. So I think I was picked because I wouldn't be too aggressive back towards them. So I was very fortunate. That's how I got to really know a lot of the luminaries in the field. I called Paul Barish up and I said, I'm doing this guideline representing our specialty, but really representing myself. Can you help me develop a team? That's when I got really quite involved in the Society of Cardiovascular Anesthesiologists and all that. That is what helped me both develop my network, but also positively interact with the august body. I think I was one of the longest serving members of any guideline committee ever.
That perioperative physician role, which in many ways you've pioneered, but has really, I guess now all around the world, people are talking about perioperative medicine, but that probably wasn't the same when all this was starting off. And I think one of the things that is coming through from listening to all these different stories is each time you get an opportunity, you really take it by the horns and sort of lead through and make progress on it. That can't be easy to do in some of these quite difficult situations, in novel circumstances, new terminology, new specialties in many ways that people haven't heard of before.
Well, that was the exciting thing about getting involved with Monty and Mike and the entire team, Paul Miles, almost everyone you interviewed in your series, is there were pockets of us all doing it around the world, including in the US. I happen to have a unique situation in that I was highly interfaced with the cardiology community and had deep contacts being at Hopkins with the surgical community. In fact, when I got nominated for the National Academy of Medicine, the Institute of Medicine at the time, it was really that crossing boundaries in the US that helped me get there. So having those friends, I still remember, the ASA saying, why should we take ownership? Let me back up for a second. So I'm very involved in these guideline committees. I end up realizing that the best way to be present, and I think all of the people you interviewed and many of my colleagues, is to just know the literature really well and to just know the evidence really well. And that's how I became the first ever non-cardiologist chair of an ACCHA guidelines. Kim Eagle, a giant in cardiology and a true hero to me, asked me to be his vice chair. And then he actually got me appointed as chair and then got me appointed to the oversight committee. And I then bring in Dominda Weiser-Sendera, another luminary, but of a younger generation than me, to be the uber methodologist to the cardiologist. So that idea of helping that next generation of what Paul did for me, and now, Dominda surpassing me as an epidemiologist and his wonderful work. So one of the things that guideline committee got me involved with is they nominated me to be on a Medicare technical advisory committee to create quality measures around surgical site infection. So I didn't represent the anesthesiologist, I represented the cardiologist. But that pulled me into the Medicare, the CMS, the Center for Medicare and Medicaid Services world. But it also took a while for the anesthesiologist to take ownership of giving the antibiotics on time. I still remember that pushback of, why are you telling us to be more responsible? But as we all know worldwide, that's the only thing that's going to continue to make us valuable in this value-based world.
And I guess, again, the evidence behind that is paramount. It's kind of making that happen. That's where the value comes from, isn't it? And as you say, it all comes back to the research and the pushing those guidelines forwards. Was that how you jumped into CMS then, and the chief medical officer role came out of that, or was there more steps in the middle?
So, I'm at Hopkins. I get invited to be chair at Penn. But while I was at Hopkins, I met a woman named Marian Couch, who became assistant, associate, and full professor in ENT, in otorhinolaryngology, at the same time as me, and left at the same time. Fortunate that I got invited to the place I always wanted to go home to my alma mater. Went to Penn. Very proud of the department we built. One of the things that I started to do, because I was chair for 17 years, Penn does 6-year terms, usually only 12 years, by exception number. My cohort got a 3rd term, but after that, you have to decide what's next. So I started talking to CMS and had been talking the whole time. And one of the previous chief medical officers was one of my students at Penn. He was in a scholars program, had been talking to them about doing a sabbatical there. And I had reconnected to Marian because she was the senior advisor to the administrator. So COVID hits. I stand up the department to COVID. But right before COVID, the chief medical officer and the director of the Center for Clinical Standards and Quality, and I can talk about that role, had stepped down. Actually became the chief medical officer of one of our insurers, Humana, Kate Goodrich, who I knew well. And I knew the person before that. And I knew Marian real well. And they had always picked sort of a primary care doc, a pediatrician and general internist. That's the sort of flavor of individual who had this role, because it oversaw all the hospitals in the country, all the quality measurement in the country, all the nursing homes, and all coverage decisions, and sat across the whole agency. But during COVID, they needed to address the acute events of what was happening. And Marian turned to the administrator and said, "You got to interview Lee," and called me up. So I interviewed for the role. It was the only career official. Everyone else at my level were political appointees, which is why I was both in the first Trump administration and the Biden administration. Given that they needed someone who could understand how hospitals operate and think about how you take care of critically ill patients, I was fortunate enough to be chosen, and I started July 5th, 2020, and stayed until the end of the pandemic. I stayed one more week, or at the end of the public health emergency, and lived 3 days a week in the Washington-Baltimore area. I had offices in both, and spent the weekends at home and still practiced. So in the United States, we had the Centers for Disease Control, which would issue guidelines on how hospitals should behave or what infectious disease processes. And we also have OSHA, which is our Office of Safety, and they had guidelines for how workplaces should behave from an infectious disease, wearing PPE, etc. So an argument erupted between the two agencies. So the White House, and when we say the White House, it's not the president, it's his staff, said, we need to figure this out. And they said, you know what? We should call Lee because he's the senior most still practicing physician in the federal government, because I was the senior career official who understood infectious disease and processes. So literally, they got OSHA on the line, which is under the Department of Labor. They got the CDC. I was there and they said, okay, Lee, tell us what would happen. So I said, well, I'm practicing at Penn tomorrow. Let me tell you what would happen depending on whose guidelines and how it would play out. And that was incredibly helpful to understand. And when I would speak to medical colleagues to say I still practiced in PPE, even though it was 2 to 3 times a month, was incredibly valuable to both the government, but also in how gave me credibility in speaking to healthcare workers.
So you must have been doing an awful amount of traveling still at that time when essentially the rest of the world wasn't traveling at all. Did that not feel personal risk, or was that just
Well, fortunately, Philadelphia and Washington in the middle of a shutdown is 2.5 hours to get from my home to the basement of the building where the Secretary of Health office and where I had one of my offices right next to the Capitol. My view was the Capitol building, and there were about 20 of us in the whole building.
Wow.
So I actually was not allowed to fly much because they didn't want senior officials on airplanes. But so I felt it was safe, and I was always distancing.
Yeah, of course. And I mean, well, I can't imagine what that job must have been like at that particular time as well. But
Yeah, I actually had brown hair before I started.
I was about to say, what are you most proud of from that period?
There's a couple things. On my wall is the vaccine mandate for healthcare workers in the United States. It was upheld by the Supreme Court. That was my decision. Incredibly proud of saying to the White House and to the Secretary's office, it's time to not only vaccinate the nursing homes, which was one of the things they thought about, but all of healthcare. And I think we protected patients. Healthcare workers are used to taking vaccines. What we do, we at Penn, you can't go in unless you've taken the flu shot. So no matter what's happening now, I am proud of that decision. I also put safety, focused on safety a lot during that time. And I have a couple coverage decisions that I made, particularly around the Alzheimer's drugs, the monoclonals, that I'm incredibly proud of, to really say, we need more evidence and we should collect it. So my EPOM, my evidence-based background, was very important to me during that time.
And perhaps this is a slightly unfair question because things are always different with hindsight, but is there anything you wish had been different during that time, or looking back that you wish had not gone the way it did?
One of the things, and it's funny, I always quote, and I think it's called Their Finest Hour, which is about Churchill's speech in government. And I still remember where 2 members of parliament, what just happened? They said they sent the English language into battle. I think we didn't do the best job at explaining why we were doing things. I was not the face of the government, but I was in the room a lot. And a lot of people said, this is factual, when in fact we were making it up. I mean, it was based upon our best evidence. We were analyzing the data. So I think one of the issues in the US right now is, how people are viewing evidence differently. I think that many in the scientific and medical community, we need to learn how to use the English language better to make people understand. When I hear, I'll just say, leadership of the CDC or others speak, I internally know all the caveats to what they're saying. The public, if they want to disbelieve them and can find one counterfactual, then everything is disbelieved. I still remember being on a plane when I said what I did, and the person next to me said, I know there are people locked up, in house arrest because they want to tell the truth about the vaccine. The vaccine saved lives worldwide.
Without doubt.
Without doubt. Did everyone need to keep taking the boosters if they were in, the 25 to 35-year-old? Probably not. What's the right risk-benefit ratio? All those things that we think about, but the public didn't hear us say. So that's what I think is unfortunate during my time.
I mean, well, it's almost how do you follow that? But I guess that's my next question. You did just a challenging job at such a challenging time, make some incredibly difficult decisions in a really difficult set of circumstances. As you say, many people have got to the end of that and said, thank you very much, I'm done now, time for a break, go back to my wonderful family, which, as you said, is important to you. But you didn't immediately. You stepped into something else. So what was next on the agenda, and why did you have that desire to keep pushing things forward?
Many of us, and Monty's doing the next phase of his career. Well, Paul may be surfing. I'm sure he is continuing to advance science. There's no way I'm going to retire. The question really is, what will be fun? I've learned so much that one of the things I love doing, whether it be to Congress or to news reporters, really explain how policy is made and how to use science and what we need for science. And I'm fortunate enough it's ironic. In about 20 years ago, I wrote with a colleague of mine who's actually now also working for a company, a piece for New England Journal Catalyst about being tri-sector leaders, having academia, federal government, and the private sector. I now have that, and it's a pulpit to be able to educate and do work. So I love what I do. I love being able to work with my son. So I think that's what's important, is to continue to give back and educate. And, my hope is that, 5 to 7 years from now, I'll probably still be doing policy. Will I be doing all the things? I'll probably be doing something slightly different, but that's what's enjoyable.
I think it's obvious that you're, how should we phrase this? Not very good at sitting still, perhaps, but I mean, to come out and then, last year, take on a law degree, finish a law degree last year, as another project at the end of an already inspirational career, all the work you're doing with your son, the company, the advisory roles. I get the feeling you're probably, and maybe this is wrong, you can tell me, but you're probably not as good at saying no to things as you are at saying yes to things. But are there any things that you have said no to along the way that were either good decisions or you regret making now?
The one thing I've said, and thank you, thank you for your kind words. I'm very proud of my career. I'm proud of having done public service. Although I put family is very important, I don't believe you can have work-life balance. I believe you can have work-life integration. What I didn't do well was when my whole family, my kids were still at home, I didn't put my phone in the other room. And I didn't divide my time up. I said yes to people having 24/7 access. Now, that might have been okay during a public health emergency because at any one time, I oversaw the nursing homes. A nursing home could be in crisis. But ironically, at CMS, they were more respectful of not calling me at night. So I think what I've learned over time is that there are times when around my daughter's wedding, then the answer was no. I'm not going to take a chance. There are meetings that if there's something important in my life, I have to say no. And now I leave my phone in the other room unless it's my kids frequently call during dinner time, but my wife and I do take our children's calls during dinner. So I think that's the lessons I learned. And, much to my chagrin, having to step away from the journal, which I do love, there's only so much bandwidth. And there are other people who could do it better. That's the other thing. I mean, who could be more devoted to this? It's time to pass on opportunities. And I'm very proud. One of my mentees, Megan Lane Fall, is now chair at Columbia. I know she's spoken at EPOM in the past. She's the foremost authority in our field, I think, one of the foremost authorities in implementation science. There are things that it's now time that they're the leader.
I think whoever steps into the editor-in-chief role of Perioperative Medicine has got some very tough shoes to follow, but there's so many things that we could have delved into and dived into. I think just for time alone, we're probably not going to have a huge amount of time to talk about the journal, unfortunately, but it's an inspirational, to me at least, conversation. I want to give you the final word on this. Just to finish off, there'll be lots of people listening who are probably, quite frankly, amazed at half the things you've done. But what would your tips or advice be to them as they head off on their career journeys in the future, build their own perioperative profiles? Any kind of final words of wisdom that you'd like to pass on to them?
Well, I think I said the thing about making sure you actually focus when you're home, you focus on home. So that's the biggest piece of advice. Number 2 is you can't decide to do something because you think it'll be right. You have to love it too. And I've loved everything I've done. It's been joyful. The last thing is surround yourself with really smart people. When I look at what my superpower is, it's certainly not being the smartest person in the room. But I used to love going to EPOM because I just would absorb all these new ideas and then take them back, and I might see a novel way to use them. But I've had the privilege to work with Amy Edmondson, a professor at Harvard Business School, and write with her. She's taught me so much. I got to work with Daniel Kahneman, the Nobel laureate. His questions open new areas for me. I think that's what perioperative medicine is about. Don't stay in the box. Learn from everybody and bring those back into our area.
Lee, fantastic advice to finish on. Thank you very much for making time for us in your incredibly busy schedule. It's been a huge pleasure, an inspirational conversation. Thank you very much for sharing your Periop profile here on Top Med Talk.
My pleasure.
Thank you very much for listening to us. As always, you can find this and every other Periop profile and our other episodes on our website. You'll find this episode to download through your podcaster of choice, whatever that may be. And as always, you'll find Top Med Talk on your social media channel of choice. We're on them all. Do hit like, do hit subscribe. It really helps us keep Top Med Talk free and open access around the world. And on that note, we should also thank our main sponsors, who this year are BD Advanced Patient Monitoring and GE Healthcare.
Top Med Talk.
Top Med Talk is the broadcasting arm of EPOM, evidence-based perioperative medicine. And this year, it's your chance to join clinicians from around the world at the EPOM World Congress 2026 at the British Library in London. Between the 7th and the 9th of July, you will have 3 days of evidence-based perioperative medicine, global insights, and expert debate, featuring speakers including Michael Marmot and Ken Rockwood. It is the main event of the year in perioperative medicine. We want to see you there. And I'm excited to tell you, super early bird registration is still available all the way up until the 31st of January. Register now at edpom.org.